Well, everybody's MS is different, all right, but I would venture that we have at least one thing in common. Well, hello and welcome to another episode of You and Me and Multiple Sclerosis. My name is Pam and I've been living with MS for 38 years. And we have a lot to cover today, so I think we'd better get right into it. Well, according to an article that I found on MedPage today, chronic pain affects 21% of Americans, according to a survey that was done by the CDC, the Centers for Disease Control. They go on to say that during 2021, an estimated 51.6 million adults, or 20.9%, had chronic pain lasting 3 months or longer, and 17.1 million, or 6.9%, had high-impact chronic pain, pain severe enough to restrict daily activities. There are a number of good sources that I found that describe pain and multiple sclerosis. And I'm going to be linking a lot of articles in the description box, but there are a few that I want to go through a little bit more. Well, if you're looking for a site that has good general information written in a way that's easy to understand, you can't do much better than the VeryWellHealth site and the articles that they have there. I'll link this particular article below. It's called What Does MS Pain Feel Like? It came out on June 20, 2022. And they say that pain in MS is complicated. To better understand it, let's divide it into the following 3 categories. Neuropathic pain, which is pain from your nervous system. Neuro means nerve and pathic means diseased. So neuropathic means your nervous system is not working correctly. I often tell people that I'd be fine if I could just get my wiring replaced, and I don't think that that's totally wrong. The next one is musculoskeletal, so that has to do with the way your muscles and your bones work, or secondary pain. So there is some secondary pain that is related to multiple sclerosis. It can either originate because you have multiple sclerosis, or it can be made worse because of your multiple sclerosis. And then finally, paroxysmal pain. Paroxysm, I think you've heard that word before. It has to do with spasms, and some of us know very well what that kind of pain feels like. They go on to talk about neuropathic pain. It's the most common kind. It's caused by demyelination. And in our body, there are nerve endings called nociceptors that specifically detect painful stimuli. When demyelination occurs, nerve signals traveling along nerve cells may get misdirected to nearby nociceptors, which mistakenly communicate pain signals to the brain. So just because you're feeling pain does not necessarily mean that that was the stimulus. We know that some MS symptoms involve pain when we feel a breeze on our face. So obviously, the stimulus is nowhere near as painful as what we end up feeling. Now, here are some of the different kinds of pain. Allodynia occurs when a person feels pain in response to a stimulus that is normally not painful, such as a person's touch or even clothing or bed linens touching skin. It is stimulus dependent, so it only lasts as long as the stimulus is present. So when the clothes are removed, the painful sensation goes away. The good news for people with MS is that allodynia is usually a short-term problem. And mostly I agree with that, but as you'll see later, that may not actually always be true. And then good old tic douloureux, trigeminal neuralgia. Often it's the French for painful twitch. Perhaps the most severely painful MS-related symptom. I can vouch for that. Tic douloureux may occur on its own, not just in people with MS. It is most commonly described as an intense, sharp pain occurring in the lower part of the face, often triggered by chewing, drinking, or brushing one's teeth. The most intense pain is short-lived, from a few seconds up to 2 minutes. You know what? If they think that's short, they've never had one that lasted that long. You think you're going to die. But a person can also experience a more chronic and persistent burning or aching in the face. The MS hug. The MS hug is the type of pain characteristic of MS that can be felt anywhere on the torso from the waist to the shoulders. It may be localized in one small area or encircle the whole body. Some people describe the MS hug as a sharp pain, whereas others describe it as dull or more neuropathic in quality, like burning, tickling, or tingling. Still others may notice a crushing or constricting sensation. Like many MS symptoms, the MS hug feels different for different people. It may also feel different in the same person on different days or at different times of the day. The pain may come and go, or it may be constant and debilitating. I have a couple of friends with MS who talk about the MS hug, and it is not a fun companion, that is for sure. They talk about paresthesia, which feels like numbness, pins and needles, burning, severe itchiness, tingling, buzzing, or vibrating sensations. Although often this is described as extremely annoying and unpleasant, occasionally the sensation can be so intense as to be painful. Headaches with people with multiple sclerosis commonly experience headaches and migraines. I believe it is more common with people with MS than it is in the general population. And that would make sense since it's related to nerves. I think anything related to your nervous system, people with MS are likely to experience that more frequently than the general population. And then optic neuritis, finally. Most people with optic neuritis experience pain when moving their eyes. This pain usually subsides after a couple of days, even if vision is still affected. Now, this is one that I would somewhat disagree with, because when they say most people with optic neuritis experience pain, I have had optic neuritis numerous times, and the only time I ever had pain was the very first time I got it. It was like having a pulled muscle in your eye. But I don't know that everyone who has optic neuritis gets pain with it. And then they talk about the musculoskeletal or secondary pain, also nociceptive pain. This is usually a result of the symptoms of MS, such as spasticity, weakness, immobility, or problems walking, and not the disease process itself. Some examples of this are joint pain. They say that many people with MS feel pain in the joints of the hips and knees due to imbalance and a change in gait. Stiffness. A person with MS may experience stiffness in the legs, arms, and hips due to immobility. Back pain. That can be the result of an unsteady gait, immobility, trying to adapt to the annoying feeling of the MS hug, sitting for extended periods in wheelchairs, or any constant adjustment in movement or position as a result of MS symptoms. And then finally, pain from spasms. Flexor spasms cause a limb to contract or bend toward the body. This can make the limb feel like it has a constant cramp or a dull ache. And then finally, now we're going to talk about paroxysmal pain. I know I'm saying that wrong. Paroxysmal pain. I don't know, that's a hard one. Say that 4 times fast. This refers to pain that has an acute or sudden onset, stays for just a couple of minutes, then fades rapidly or disappears completely. However, there may be residual or lingering pain after the episode. Painful paroxysmal pain symptoms include the tic douloureux, which we've already talked about, good old trigeminal neuralgia, extensor spasms. They're when a limb, usually a leg, stiffens and the person is unable to bend the joint. These cause the limb to jerk away from the body. Extensor spasms are usually not very painful, but can be forceful enough to make people fall out of their wheelchairs or beds. I have a friend who's dealing with this right now, and she says that it's enough to make her knock things off tables or whatever. She just cannot control that jerking movement in her hand. And it's also something she deals with as far as the leg, which stiffens and she's unable to bend it. And then Lermit's sign, that one is the one that we all know about, but this is perhaps a new term for you. It's the electric shock type of sensation that runs down the spine when the head is bent forward. I have not experienced that, but I do know many MS I do know many folks with MS who do experience this. One source is someone that I haven't really talked about before, but she has a number of videos. She's a pain specialist, and she has a number of videos. The one that I'm going to be looking at later on is specifically about pain in multiple sclerosis. And her name is Dr. Andrea Ferlin, and according to her website, she's a pain specialist in Toronto, Canada. She's a physiatrist, which is a specialist in physical medicine and rehabilitation. She holds a medical degree from the University of Sao Paulo and a PhD from the University of Toronto. She has 30 years of experience helping people with chronic pain to get a better quality of life. And as I said, she made a video specifically about pain and multiple sclerosis, which I will link below. As she says in her video, she's going to explain what kinds of pain people with MS may have and how to treat it. The statistic that she gives is that not everybody with MS will have pain, but according to her, more than 50% do. I have seen other statistics that go as high as 80%. When you think about pain as something that may not be with you constantly, but may in different phases of your MS come and go, I could say it's probably closer to 100. I have yet to meet someone with multiple sclerosis that has never had any kind of MS-related pain. Dr. Ferlin reminds us that not all pain is related to MS, as much as we might think it is. We can probably find articles to refute that, but let's face it, not all pain is related to MS. If you stub your toe or break your arm, they hurt, but they don't have anything, at least directly, to do with MS. We could make the connection, of course. MS makes you klutzier, all kinds of other things, but I went out and looked at the Cleveland Clinic's website. They have an article in there about pain and multiple sclerosis, and the part that I particularly wanted to look at was how often do MS patients have pain? And they said that pooled overall pain prevalence in a systematic review of 17 studies with 5,319 subjects was 63%. The quantified prevalence of specific pain in this study was as follows: headache, 43%, neuropathic extremity pain, 26%, back pain, 20%, painful spasms, 15%, Lermite sign, 16%, and trigeminal neuralgia, 3.8%. It says here that compared to controls, MS patients were more likely to have moderate to severe pain, use analgesics, and describe interference with daily activities. Pain has been associated with poor quality of life measures. Risk factors associated with increased pain in MS patients include older age, longer disease duration, and greater EDSS scores. So the further along you are in your MS journey, the more likely you are to have pain. They had a very useful table, pain syndromes according to lesion locations. So in other words, there are different places in your brain where you might have had lesions or have active ones, and the pain that you have is related to where it is in your brain. So according to this table, demyelinating lesions on the nerve entry zone might be the cause of trigeminal neuralgia, glossopharyngeal pain, spinal roots, or pseudoradicular syndrome. And then demyelination in the sensory pathways would lead to pains like chronic paresthesia, Lermite sign, dysesthesia, pain syndromes that include spinal cord lesions. And then secondary complications of MS would include optic neuritis or eye pain, partial myelitis, and myelitis is inflammation of the spinal cord, severe spasticity, musculoskeletal or related to disability, and headaches such as migraines and other kinds. They do give, in their article, they do talk about the kinds of medications that are routinely used for multiple sclerosis pain. But I did appreciate that in addition to that, they said that they also encourage people with MS to use non-medicinal approaches to pain and wellness, so that there are things we can be doing ourselves without a prescription to help with our pain. And the things that they recommend are meditation, exercise, consultation with integrative medicine, nutrition therapy, smoking, and I think what they mean here is not smoking, because it would kind of be counterproductive to start smoking so that your pain went away. Sleep hygiene, aquatic therapy, yoga or chair yoga, and then behavioral medicine approaches. And those are all, a lot of those are things that we have talked about in previous videos. Now, the National Multiple Sclerosis Society also has a good article on pain and MS, and here's an excerpt from that. Similar to the other one, they have a table, and it says that below are examples of some common approaches to treating the different types of pain experienced with MS. Before starting any treatment, prescription, or over-the-counter, please discuss with your healthcare provider. And here are on the left-hand column is the type of pain, and in the middle column is the treatments that involve drugs or prescription medications, and on the far right there are the non-drug treatments. So for neuropathic pain, including dysesthetic itching, the pharmacological treatments would include anti-seizure medications, certain antidepressant medications, but the non-pharmacologic treatments would include acupuncture, mindfulness, meditation, cognitive behavioral therapy. So those are all things that you can look into more if you're interested in that, and maybe we can do some videos on some of that stuff as time goes on. Musculoskeletal pain can be treated with analgesic medications or non-steroidal anti-inflammation drugs, but it can also be treated with physical therapy, massage, or application of cold or heat. And I should make the same disclaimer that I'm sure they're going to make, that non-pharmacologic treatments don't necessarily take care of your pain. But it's probably worth a try, at least I think. It's worth a try going with something that's non-medicinal first to see if you can make an improvement without having to go on some kind of a prescription medication, which would have its own problems. And then finally at the bottom here, spasticity. The pharmacological treatments would include muscle relaxant medications, and the non-pharmacologic treatments would include stretching exercises, aquatherapy in a non-heated pool. And that's a good point, because a lot of us with MS, we cannot bear to be in hot water for very long. They also talk about the emotional impact of pain, and I thought this was very insightful for them to mention this. They say that emotional changes, including fear and worry, may contribute to physical pain. A multidisciplinary pain clinic may be able to treat chronic disabling pain with medication in combination with alternative therapies such as biofeedback, hypnosis, yoga, meditation, or acupuncture. Self-help and/or group support may also play an important role in pain control, and you've heard me say this a number of times, that I find my MS support group to be extremely helpful. And then finally, people who stay active and maintain positive attitudes are often able to reduce the impact of pain on their quality of life. So those are all things that you can try, and probably some of you already do. But I'm a big believer in addressing some of the lifestyle modifications that we can do before we start getting ourselves involved in heavy-duty pharmaceuticals. Now back to Dr. Ferlin. She talks about the 3 kinds of pain. And I found this to be very interesting because I didn't really know some of this stuff. And so she said the first step when you come in with pain is to diagnose what kind of pain the person has. And it's not just a question of where it is in the body, it's what's causing it. The first one she talks about is nociceptive pain. And she says people with MS may have pain from inflammation, arthritis, myofascial trigger points, or tendinitis. There may actually be a condition that you have that's causing you pain, that does not have anything to do with multiple sclerosis. Strange as it may sound, that may be true. So it's very important to diagnose that that is the problem. That is the root cause. That's why you're having pain. The second kind is the kind that we're very familiar with, neuropathic pain. That's almost the definition of MS. I'm pretty sure that almost all of us have had neuropathic pain at one time or another. That is very common in MS because MS is a disease of the nervous system. Neuropathic, of course, means exactly that. Neuro is nerve and pathic is disease. And then finally, she talks about nocioplastic pain. People with MS may have nocioplastic pain. This is because the pain system has been sensitized by the other types of pains and is now malfunctioning.
Okay. This is the typical mechanism for chronic pain. After the nociceptive or neuropathic pain have been resolved, the injury has been healed or the myelin has been repaired, the pain system had been sensitized, and now there is no more injury or lesion, but there is a memory of the pain in the brain. And the person keeps feeling pain even after many years that the original injury has healed. So we need to retrain the pain system to get rid of those past memories of pain. And of course, there are people who have a mix of all these three types of pain.
I recently started subscribing to a free online newsletter called MedPage Today. And the recent edition of it had a link that's quite relevant to what we're talking about here. It's from BBC Future. And the article is titled How an Objective Measure of Pain Could Counter Bias in Medicine. And we don't have to just be talking about multiple sclerosis to realize that there definitely is bias in medicine. If you go in with pain that can be measured, like a broken arm or severe abdominal cramps, they can do objective tests and measures to know that you're in pain. But a lot of the types of pain that we have are neuropathic in nature, and those don't show up on any kind of objective scan. You can't do a blood test for it. They don't show up on an MRI. So it comes down to whether or not the doctor believes that you are telling the truth, that you're not exaggerating your pain or even making it up entirely. It's all in your head, whatever. I think that we've run into some situations like that. Sadly to say, it tends to be worse for women and for people of color. The studies show that's true. So if we could come up with an objective way to measure the kind of pain that you can't see, wouldn't that be nice? Let's see where this stands. I'll read parts of this article for purposes of this video, but I will link the whole article below. It says, could new technologies help provide a way to circumvent prejudice and bias about pain in medicine? Several innovations are being developed to try to plug this gap to provide an objective readout of the extent of someone's pain. These technologies rely on finding biomarkers for pain, measurable biological variables that correlate with the experience of pain. And those would be useful, right? Because you can go from one doctor to the next and they've got something in common they can look at to understand the level of pain that you're experiencing. The article goes on to say, without biomarkers, we will not be able to properly diagnose and adequately treat pain, says Saab, who is the physician they're quoting here. We will not be able to predict the likelihood of someone with acute back injury to transition to chronic treatment-resistant pain, and we will not be able to objectively monitor response to novel therapies in clinical trials. They say that there are several candidates for biomarkers. Researchers in Indiana have developed a blood test to identify when a very specific set of genes involved in the body's response to pain is activated. Levels of these biomarkers could indicate not only that someone is in pain, but how severe it is. Brain activity could be another useful biomarker. Yeah, I could see that. Saab and his team, while he was still at Brown University, devised an approach which measures the ebb and flow of a type of brain activity known as theta waves, which the team found were elevated during pain. Saab also found that administering analgesics reduced theta activity to normal levels. Yeah, I kind of see where this could be really useful, because you know as well as I do, when you're in pain, your body tenses, you're under stress. It's kind of hard to fake that, and you would think that there would be some way that they could measure that biologically. They'd know that you were telling the truth, and they'd also maybe be able to get a good idea of how severe the pain was. The team's work has since been independently replicated by other labs. However, and of course there's always a however, Saab sees theta wave-based assessment of pain as an add-on rather than a replacement to current methods of measuring pain. Well, since they just got done telling us that the current methods of measuring pain are very inadequate, I'm not really sure what to make of that, but we shall see. They go on to say, we will never be able to know for sure how someone feels, be it pain or another mental state, says Saab. The verbal report of the patient should always remain as the ground truth for pain. I envision this being used as an adjunct diagnostic, especially in cases where the verbal report is unreliable. Children, adults with altered mental status, non-communicative patients. Saab makes a distinction between acute pain, which functions as an alarm, in which case we would not be ignoring it, and chronic pain. So what he's saying is chronic pain tends to get ignored worse than acute pain, which is a shame because chronic pain becomes much more impactful on your life. The article concludes saying, despite these challenges ahead, Saab believes there is an appetite for change in the field of pain. That is so good to hear. Clinicians are saying, look, we can't base our clinical workflow on this. It's not how medicine should be practiced. When you have a high temperature, you use a thermometer. When you have high blood pressure, you test your blood concentrations. In this case, people come in with pain and we show them smiley faces. Well, that about says it all. I'm encouraged by the direction of this research, and if I get any updates on it, I'll let you know. Well, I hope you found all of that a nice mixture of things you kind of already knew and things that you learned that you never knew before. I think for me, the most interesting thing was the idea of the nosoplastic pain that we have, the memory of pain that makes our pain continue on long after the actual stimulus for the pain is gone. And I've wondered if that has something to do with the way we are as humans, that we worry about the future and we remember the past, and, you know, sometimes the present gets kind of third billing in our scheme of things. All of that is good information to have, I think, and just to recognize that sometimes the pain that we have. But that's all I have for you today. All I ask is that you take really good care of yourself until I see you again in my next video.